Well, I think this sort of brings us into the next set of discussion questions, which is what do we do for patients progressing on CDK4/6 inhibitors? This is really a huge issue, and we have a lot of patients in this situation. There's many trials looking at this. Of course, we've got the recent approval of alpelisib for the PIK3CA mutated group. Adam, what are your thoughts on the options, and how do you go about? Are you routinely biopsying at this point, or are you biopsying up front? How are you managing and both diagnostically and therapeutically?
So let's start with kind of what we think the mechanism may be, and we'll go from there. I mean, I think that it's important to note that resistance to an aromatase inhibitor in CDK4 could be resistance to the CDK4 or resistance to the aromatase inhibitor. And I think what a lot of us are doing now, because alpelisib has been approved, is doing the PIK3CA testing. And I think what a lot of us are doing, at least we do in my practice, is we don't really use the FDA cleared or FDA suggested biomarker companion diagnostic, but in fact we use something like a Garden, that we will do CtDNA testing. And whatever we get out of that CtDNA testing will kind of guide what we do. So for example, if they have a PIK3CA mutation, I think that we probably would use fulvestrant and alpelisib based on the SOLAR trial. In that trial, obviously, you had women who got alpelisib and fulvestrant versus fulvestrant alone, and had, I think, a median PFS of about 11 months versus about 5 or 6 months, about 5.5 months or something like that. So clearly it's beneficial. In that trial, about 6 to 7% of the patients, I believe, had prior CDK4/6 inhibitors. Wasn't huge, but in that limited subset, they also benefited as well, understanding it was small numbers. So it is a reasonable option after. I mean, I think my go-to therapy before that had been probably fulvestrant and everolimus. There's very nice randomized phase 2 data from the PRECOG study, the PRECOG, I think, 0102, showing, again, about an 11-month PFS with fulvestrant and everolimus. The problem being none of those patients had prior CDK4/6 inhibitors, so it's hard to know what to make of that. So really, I would be guided kind of by that and kind of go and say, if someone has, for example, an ESR1 mutation, obviously they'll need fulvestrant, maybe fulvestrant and everolimus. If they have a PIK3CA mutation, maybe they'll get fulvestrant and alpelisib and go forward. And just to mention, my experience with alpelisib, I think, has been a little bit better than I thought it was going to be. I do fasting glucoses every week, start metformin very quickly. If their glucose is over 140, 150, start them on Zyrtec or Claritin to kind of help with the rash. So for me, it's actually been working pretty well. But nonetheless, that's kind of how it would go. Now, there's been a kind of an experience. In fact, a group of Florida cancer specialists at this meeting actually also gave their experience with just changing the CDK4/6 inhibitor and continuing the hormonal therapy. So Joyce and I and Kevin Kalinsky and Atidya Bhartia's groups put together an experience of, I think, about 80 patients, something like that, who were given abemaciclib after progression on a palbociclib-containing regimen. And in that trial, if you immediately got abemaciclib afterwards, you had about an 8.3-month PFS. So clearly you're getting a benefit from that.
Without change in endocrine therapy?
Without change. Well, just taking abemaciclib, I think, as a single agent.
It's a single agent, right?
And it was a case series. It was a case series.
It was a case series.
So
it wasn't a
was
randomized
mixture.
trial. It wasn't controlled. And if you had at least one intervening regimen, your PFS went down to about 4 months.
So I have a question for the group as well about ESR1 mutations. Many of you listening out there are obviously ordering next-gen sequencing, and we generally think of ESR1 as clearly a mechanism for AI resistance. Maybe they should be on fulvestrant. The plasma match study actually did not really show much in the way of responses there. And any insights on how we should be handling that therapeutically?
Don't pay any attention.
Yeah,
Really?
right.
Don't pay attention to it? You
No,
wouldn't pay
because
attention
if
to it?
we're already using the order of AI, fulvestrant AI, right? So why does it matter if they have an ESR1 mutation or not? I mean, I do NGS, but it's certainly not to find an
But
ESR1
Hope, so if you have
mutation.
AI, so if you have someone on AI, right, say letrozole and palbociclib, and you do NGS looking for PIK3CA, and it shows they have an ESR1 mutation, would you consider putting them on abemaciclib?
If they're not progressing?
Well, no, they're progressing. So they've now progressed, okay?
But then I'm
then
going to
with
put
the
them on a
normal
fulvestrant and a CDK, or I'm going to put them on something, that includes fulvestrant. I don't know that
But would you continue
abemaciclib.
the CDK4 is the question.
Oh, but I don't, because there's no data to continue through
That's what
progression.
we're
And
trying to talk about. That's what
but
we're
I
talking
don't
about.
think that there's data to support abemaciclib as targeted against ESR1 mutations. But I think we should switch to fulvestrant, which I do, with progression.
Right, but there are these encouraging sets of data that are
Correct,
now
it's
coming out
encouraging, right.
suggesting that CDK4/6 inhibitors may have benefit after prior progression. We have, you just mentioned the study, the multi-center study that you guys looked at that showed, 36% of patients had
Clinical benefit.
disease
Clinical
control for
benefit,
6
right.
months.
Correct.
That's significant. There was another poster presented from a Florida group
Right,
that
Florida
showed,
Cancer Specialist Group, right.
yeah, it showed 25%, I think, clinical benefit in that same patient population. What we need to do is establish, who are the patients who benefit and who are not. I actually was wondering in your study, did length of time on the first CDK inhibitor predict benefit in the second?
I don't think
It did in that abstract that was presented. The poster was presented here at San Antonio. It did. So what they did is they characterized the long-term responders to the therapy, and almost all of them had a really prolonged response to their initial therapy.
But I will
I think we
caution
hit
that
on that.
this is retrospective.
Of course it is.
You're picking out the best people, but it is encouraging, and we have prospective trials that are going on.
But they're very
I don't
small
think this-
trials, Hope. They're
if
200.
we
I mean,
bring
the one
it
from
back,
Dana-Farber is 200 people. It's
if
not
we
that
bring
big.
it back to ESR1 mutations, they don't help us with this question. So it's really the question of, are you going to use fulvestrant? And so I think, I tend to use abemaciclib alone when I don't have an endocrine partner to give, because they've run through them all. But again, I still don't think, and ESR1 mutations, unlike PIK3CA, and RB and FGFR, they come and go, right? So it's one of the only ones that goes.
I don't know if you guys agree. I think the data are emerging that if you have an ESR1 mutation, that your chance of benefiting to any endocrine therapy, including fulvestrant, is quite low. I'm hearing about median PFSs of 2 months or less. But I would also say the good news is that when you partner these agents, which we're increasingly doing, that they seem to be more agnostic to the ESR1s.
But the question, that's the question. So the whole idea behind oral SERDs, or one of the many ideas behind oral SERDs, is that some of them have, at least preclinically, in preclinical cell lines, responses to the oral SERDs that you don't have with the fulvestrant. That's kind of part of the apparent theoretical benefit.
Yeah, so we really await the results of some of these trials.